All right, you guys. So again, my name's Anuj Malhotra. I'm an interventional radiologist at NYU Langone Long Island Hospital, and I will be talking about the abre stent. Here are my disclosures, nothing relevant for this talk. And so the abre stent is one of the many new dedicated venous stents. It is a bare metal, self-expanding, open cell nitinol stent that comes on a 9 French platform. It is a triaxial delivery system with a thumb wheel deployment, much like many of the newer stents that we use today, with a 90 centimeter working length. It's got a sizing matrix that's appropriate for venous-related work, with diameters ranging from 10 to 20 millimeters in size, and lengths both short and also long for long venous segments. Now, as you guys will see, there's a common theme in that really most of the newer venous stents all perform really well. But I think it's worth pausing for a second and really paying attention a little bit to sort of the work that the Medtronic team and the abre stent design, the team put into the abre stent design. And so if you think of a venous stent, it's really designed to withstand certain types of forces. Those include bending, compression and just shear axial forces. And so I thought this was kind of interesting to look at. And so the engineering team put a lot of design and thought into this and sort of preparing a stent to handle the stressors in when a stent is deployed in a vein in a patient for years to come. And they sort of try to simulate what happens to the stent within the body in a lab. And so I think it's just kind of interesting to take a look at. And with that in mind, we'll shift to the data that we have, which is the abre study. This is the IDE study, industry-sponsored, a multi-center, international, prospective observational study. And in this study, there are 200 patients. Patients with all three sorts of pathologies were evaluated. So those with chronic venous occlusion, so patients with PTS, PTS patients and NIVL patients. For patients with chronic venous occlusion, they had to have a SEEP score of at least 3 and a pain component of their VCSS score of at least 2, along with at least a 50% diameter reduction on venography or a 50% area stenosis on IVUS. The study also looked at patients with acute DVT. Of note, 88 patients out of the 200 were stented below the inguinal ligament, which I think is, again, interesting. So primary endpoints, much like all the other venous-specific observational studies, so primary patency at 12 months. This includes looking at freedom from occlusion of the target lesion, freedom for a significant stenosis, and also freedom from a clinically driven target lesion revascularization procedure. Primary endpoints also included major adverse events at 30 days, looking at death, clinically significant PE, major bleeding, in-stent thrombosis, and stent migration. There's a lot of secondary endpoints, mainly looking at procedural success, and then a lot of the same things that we see in the primary endpoints, but evaluated at different time points. So for example, patency at 24 and 36 months, primary assisted and secondary patency at 1, 2, and 3 years, freedom from revascularization at multiple time points, major adverse events, stent fracture, and also quality of life metrics, both venous specific and overall quality of life metrics. And so what was the patient population in this study like? So this, if you look over here at this sort of pie graph, you can see that really all 3 types of patients were treated. So almost half the patients were those with post-thrombotic syndrome, about a third were those with NIVLs, and a little bit less with those with acute DVT. 92% of the limbs treated were the left limb, and the rest of the demographics are pretty standard for the venous population requiring intervention. If you look at target lesion characteristics, so again, right, typical of what you expect considering a lot of the patients in the study were post-thrombotic in nature. So stent diameters of around 15 millimeters reflecting common iliac vein stenting. Long lesion lengths, 111 millimeters reflecting, again, post-thrombotic disease. Long total stented lengths of around almost 15 centimeters. And the average patient required 1.5 stents. Again, common iliac vein being the most common stented vein, followed by the external. And again, remember, 44% of patients actually had below inguinal ligament stenting here. If you look at the cohort of patients that were stented below the inguinal ligament, 71% had PTS, which is not surprising because inflow disease is a real problem with post-thrombotic syndrome, and so therefore stenting lower down is to be expected. 17% had acute DVT and 13% were nivels. So what were the endpoints and what were the results? So as far as primary safety endpoints are concerned, only 2% of patients had adverse events within 30 days, and 88% of patients, all comers, demonstrated primary patency at 12 months. These numbers are very similar amongst all sort of venous stents, in line with sort of the things that we're now starting to see from newer technology. Secondary endpoint of 36-month primary patency, pretty impressive at about 82%. And if you further break that number down by etiology of disease, it's not surprising that the nivel patients had near 100% patency at 97%, and then you had your acute DVT cohort at 77%, and the PTS patients dipping down to about 70%. And so this is sort of in line with everything we've seen in several other studies so far. Target lesion, so freedom from target lesion revascularization overall was a secondary endpoint, and that was 84% at 3 years. The primary endpoint was freedom from clinically driven target lesion revascularization, and that was nearly 90% at 3 years. As far as the complications are concerned, really a majority of the complications were driven by in-stent thrombosis. There was a few cases of PE, and there was a couple cases of death post-procedure, although not directly attributed to the procedure itself. No major bleedings related to the procedure, and no stent migration was seen. This is obviously crucial: no stent fractures or no stent-related migration. Quality of life metrics, so venous-specific quality of life metrics, and these trends sort of reflect in all quality of life metrics. The acute DVT patients benefited the most, followed by your nivel patients, followed by your PTS patients. So venous-specific scores, I mean, I'm not going to belabor the point, but you can see there was an improvement in sort of all three cohorts of patients. Overall quality of life metrics, generic health status improved for all three metrics as well, all three cohorts as well. Villalta score improvements for all three cohorts as well, and venous clinical severity score improvements for all cohorts as well. That's it. Thanks, you guys.